Hey guys, welcome back. This is Dr. Marwah, and today I'll be discussing MCQs of the recently conducted NEET PG 2021 with you. I'm calling it a landmark exam from the perspective that not only was it postponed and there were a lot of controversies, but on the day of the exam, there were torrential rains. At least in North India, it was flooding everywhere, and the students had to literally wade through knee-deep water to reach the examination center. In fact, I would like to highlight the fact that one of the students sarcastically messaged me and said, Sir, I literally swam to the examination center. So, hats off to the dedication of these guys. And with these opening words, let's get started for this discussion. The first one is from cardiology. He spoke about a 56-year-old patient who's admitted with complaints of recurrent episodes of retrosternal pain, with each episode lasting 3 to 5 minutes, and was relieved on sublingual nitrates. The biomarkers of this patient is normal. Now you very well know biomarkers will take about 3 hours to turn positive. So there can be two possibilities. Either this patient of acute coronary syndrome has reached the hospital early, that is why biomarker is normal, or for that matter of fact, he could be having a presentation of acute coronary syndrome where the biomarkers are still normal. So I need to look at the ECG to find out what's going on, and the ECG is showing features of left ventricular hypertrophy. So this tells me probably he was a hypertension patient, maybe did not take medication on a regular basis and end up with hypertrophy of the heart. The ECG shows a T-wave inversion or a T-wave flattening. Now I had some guys saying T-wave inversion, some guys saying T-wave flattening, but the message is if you combine the presentation here, chest pain, recurrent episodes, normal biomarkers, and T-wave either showing a flattening or an inversion, then the first differential diagnosis of this patient is unstable angina. What happens in unstable angina is that there's a formation of a clot in the coronary artery which gets disintegrated by the inbuilt anti-clotting system of the body. You very well know the fact that protein C, protein S, antithrombin 3, they're gonna break down this clot into multiple small pieces. So what happens in unstable angina is a shower of emboli that are gonna land up in the ultra small blood vessels. The ultra small blood vessels would be called as perforators. I want to highlight this fact that out of the differential of acute coronary syndrome where we have STEMI or we have a non-ST elevation MI or we have a unstable angina as a presentation, do remember the fact that in unstable angina, because ultra small blood vessels are getting involved, so the necrosis would be on the minimal side or hardly present initially, and therefore biomarkers can be normal in these patients. He mentions the fact that the patient is already on statins, that's primarily to curtail the atherosclerosis component, low dose aspirin, metformin, and metoprolol 50 milligram. In fact, metoprolol maybe would have been started for two reasons. One, this guy was having a pre-existing hypertension, and it will also reduce the oxygen consumption of the heart. The question specified or said what is the next best treatment for this chap. Now in any patient who's having a shower of emboli, you primarily need antithrombotic therapy. Option A says increase the beta blocker dosage. There are two reasons why I would not like to answer A as the correct answer for this question, because if I increase the beta blocker dosage, number one, it's not going to do anything for the microemboli which are forming in the coronary circulation. They would still continue to go into the distal circulation and would contribute to episodes of chest pain. And the dilemma would be that should I in this particular patient try to control oxygen consumption, or should I try to neutralize the emboli? Then my decision would be to neutralize this shower of emboli. If I still persist with option number A, increase beta blocker dosage from 50 to 100 milligram, you see, I might actually decrease the heart rate of this patient. It's not given. The value of heart rate is obviously not given in the question, but the point is, if the heart rate of this patient dramatically decreases due to a higher dosage of beta blockers, you could actually decrease the cardiac output, decrease the coronary blood flow, and may paradoxically worsen the patient. I repeat the fact once again, option number A can be counterproductive at the moment, because if you decrease the cardiac output of this chap, the coronary blood flow reduction might actually worsen the chest pain. Option number B, low molecular weight heparin, looks like a usual scenario because I mentioned mnemonic by the name of ABE-MON. Alphabet A would stand for epsiximab. That's one of the primary weapons that you use in unstable angina / non-ST elevation MI. Then is obviously beta blockers. They have already been given in the patient. And the next step is enoxaparin. That looks like the plausible answer to this question. MON you very well know, morphine, oxygen, aspirin, nitrates. That really, is a no-brainer. So B definitely looks very promising. Now let's look at C, IV nitroglycerin drip. IV nitroglycerin drip is used two times. One, if a person who's having acute coronary syndrome is having persistent chest pain. Then to relieve the distress of the patient, I would say chest pain relief is one of the indications for giving nitrates to the patient. In our case, since the patient was having relief from the buccal spray or the sublingual tablet that was given, then there is no need for IV nitroglycerin. Another indication is when you give IV nitroglycerin is the person is having acute pulmonary edema, though you need to keep a watch on the blood pressure. Now, both of these scenarios are not given in the question in a sense that my patient was having relief of chest pain. No, that was given in the, I would say the third line of the question, that the chest pain of the patient is getting relieved on sublingual nitroglycerin. If you read the third and the fourth line, I mean, that's why nitrates are off the discussion. And there was no mention of any pulmonary edema. I'm left between either clopidogrel or low molecular weight heparin. My point is, if I want to control this problem, that is the shower of microemboli, then I primarily need to use heparin for this patient. So the most plausible and the correct scenario, or I would say the most plausible explanation for why would you be using heparin in these patients would be to neutralize these microemboli. I need to use antithrombotic agents. At this juncture, a query from a lot of you would be, sir, why would not be clopidogrel useful for this patient? Then one, I want to say that if I will give a tablet of clopidogrel, it will take some time to act. That's point number one. Second, clopidogrel or Plavix may not be very, very effective in Indian patients. I agree to the fact that dual antiplatelet therapy should be given to all patients who are having acute coronary syndrome. But the reason why I'm ruling out clopidogrel here is one, if I give it orally as compared to drug that I'm giving subcutaneously, I can definitely have, I would say, a better improvement of my patient from option number B as compared to option number D. Apart from this, I am also going to show you a Harrison reference where he has mentioned level of evidence for both these interventions. The message from a lot of my students was that, sir, in the protocol in Harrison, clopidogrel is given first. So should not the answer be add clopidogrel? In fact, dual antiplatelet therapy or DAPT is required in all cases of acute coronary syndrome, and I've highlighted that in the routine lecture. But the point is, at this moment, if you look at the data, level of evidence A, that is valid for enoxaparin, level of evidence B is for clopidogrel. So even from the textbook perspective, it's gonna be enoxaparin, which is gonna be first and the best treatment for this particular patient. The message from this particular question would be that he is trying to evaluate your knowledge of acute coronary syndrome. So do have a look at the unstable angina component that I've discussed in acute coronary syndrome lecture, and you would be in a much better state to understand and answer questions related to similar kind of scenarios relatively better. Coming to the next question, he spoke about a 30-year-old patient with a weight of 70 kg who was admitted due to multiple episodes of seizures. And during the workup of this patient, it was found that the sodium of this patient is about 120 milliequivalent. So hyponatremic seizures was the presentation, and I need to correct this with hypertonic saline. So for this particular chap, I need to definitely give a correction. Now in the question, he did not ask what is the correction per day. Rather, what he asked was what is the total sodium deficit in the patient. So let's look at the basic formula that has been discussed. The formula would be desired value minus actual value into total body water. Total body water, depending on the gender per se, if it's going to be a male patient, then the total body water would be weight multiplied by 0.6. For a female, it would be weight multiplied by 0.5. You all know that. But the bottom line is, in this MCQ, he asked per se, what is the total correction to be given, not correction per day. Why that is important for you to know is because if you will try to correct the entire deficit in a single day, it will cause osmotic demyelination syndrome or will cause central pontine melanosis. So the desired value in this case, because he is asking for the total, will be 140. The actual value is 20 and the remaining is mathematics, and you just need to multiply these figures. This will work out to 1400 multiplied by 0.6, that is 840 milliequivalents. But before I mark the answer per se, I just want to highlight the fact that suppose in this same multiple choice question, he said what is the correction to be given to this patient per day, which could have been a possibility because obviously there can be variations in recall as well. If it is how much corrections to be given per day, your desired value will be then 128. You upgrade in 24 hours from 120 to 128, from 128 to 136, and so on. So the upgrade has to be gradual because of the risk of osmotic demyelination syndrome. The mathematical factor of weight multiplied by the multiplication factor would still remain the same. And if you just run through the mathematics here, the value will turn out to be 336 milliequivalents. The correct answer for this question is beta. I'm very sure the same kind of question because our examiners somehow, they always tend to ask regarding hyponatremia. So I want you to be very particular regarding the fact that if they say total deficit, the desired value has to be kept in as 140. That's an average of 135 to 140. But if they say how much is the correction to be given per day, as I've discussed in the app, then it would be 8 milliequivalents hike on a regular basis. And the reference for that 8 milliequivalent hike is the latest edition of current medical diagnosis CMDT per se. Moving to the next question. He said there's the female patient with hysteria and she was hyperventilating. She subsequently developed a carpopedal spasm. So I think the question can be solved just by the hyperventilation word. There would be carbon dioxide washout from the body. So the production of protons will be lesser and the patient will end up with respiratory alkalosis. And this respiratory alkalosis per se interferes with calcium values per se. You see, calcium exists in two format, that is the ionized format and the bound format. So usually alkalosis that contributes to decrease in the values of the ionized calcium. And once the ionized calcium values will decrease, they can definitely be triggering tetany in the patient or can trigger carpopedal spasm, which is one of the manifestations of tetany. He also gave the ABG status. The pH of the patient was 7.53. So pH is elevated and PCO2 is 20, it is less. Bicarbonate values are given to be normal. It's a range of about 22 to 26. Whenever pH and PCO2 go in opposite direction, it has to be a respiratory problem. In a respiratory problem, the decision whether I want to say acidosis or alkalosis is not based on bicarbonate. I repeat my fact again. In respiratory problems, the decision to call it acidosis or alkalosis is not based on the bicarbonate value, but is rather based on the pH per se, which in this case is anyway elevated. And I said you really do not need the ABG interpretation to solve this question per se. I mean, the moment you read hyperventilation, the moment you read about carbon dioxide washout from the patient, you can narrow down to the diagnosis of this patient. And I've discussed a similar kind of a question in the I would say the app as well. I mean, not exactly the same, but the gist of the question, the concept is same, that a patient having respiratory alkalosis would be developing what kind of a derangement from the electrolyte perspective. Then patients having alkalosis of any etiology, it could be metabolic, it could be respiratory, definitely end up with development of tetany, which is the one that was given in this scenario as well. The answer to this question is option number beta. Coming to the next question, he speaks about a 30-year-old patient who's behaving very strangely and developed an episode of seasonal presentation to the ER. So he gave you again a CNS presentation in the case. And he said that when the doctor was working up this patient for the etiology behind seizures, it was found that the urine osmolality of this patient was increased. I mean, normal is a range of about 100 to 900, and you can see that the urine osmolality of this particular case is elevated and plasma osmolality is lesser. Normal is 285 to 295, and in this case the plasma osmolality was about 200 per se. So arrows are going in opposite direction. Whenever you read a question in which urine osmolality and plasma osmolality go in opposite direction, there is always antidiuretic hormone that will come in the picture. And the moment you realize that, all you need to then think in terms of, is it diabetes insipidus, is it SIADH per se. One, I have always highlighted that whenever a question begins with CNS etiology, whenever he talks about a patient having a brain tumor or a meningoencephalitis or a brain abscess per se, or even a plain meningitis, one of the biggest problems in all CNS problems is endocrine issue that crops up, that is syndrome of inappropriate ADH secretion. Now what's going to happen in this case is all the water is going to come back in the body. When all the water will come back in the body, it's going to cause a hyponatremia, and that was per se asked in the MCQ, that what is the probable dyselectrolytemia present in this case. The answer for this would be hyponatremia per se. There are two catches that you need to evaluate in this particular question. Catch number one, whenever urine and plasma osmolality go in opposite direction, antidiuretic hormone is to be blamed for. Though I have discussed comparison with even psychogenic polydipsia and adipsic hypernatremia, But at the moment, one you can narrow down to antidiuretic hormone coming in the picture, and whenever you are having CNS picture coming up, that's a standard statement. When you listen to the discussion of euvolemic hyponatremia versus hypovolemic hyponatremia, electrolytes are, I mean, an integral component of our exam. You will notice me highlighting that the important cause of SIADH. First, don't answer it as carcinoid tumor or lung cancer. I mean, yeah, they are important causes also because they're ectopic sources of antidiuretic hormone per se. But over and above lung cancer, over and above bronchial carcinoid per se, or a midgut carcinoid per se, it is rather, I would say, the terminology that I highlighted, that CNS causes, it could be CNS infections, even head injury described in the question, which is one of the important causes for development of SIADH, and therefore the dilutional hyponatremia component would explain this. I also want to add to the fact that in patients of SIADH, total body water will definitely be increased. Total body salt is normal. I said hyponatremia. Now you might just say, sir, on one hand you're saying hyponatremia, on the other hand you're saying total body salt is normal. Yes, guys, that's how the nomenclature is. If total body water is increased and total body salt is normal, it will still cause a hemodilution. No? The dilution part, I can casually say the word dilutional hyponatremia, but from a doctor's perspective, we will use the word euvolemic hyponatremia. I want to highlight euvolemic word per se does not mean that it is normal total body water. It basically means that there is an increased total body water of this patient. That explains the hyponatremia component coming up. The answer to this question is option number delta. Coming to the next question, he talks about a child born with congenital hydrocephalus and a ventriculoperitoneal shunt was put. Probably he was having aqueductal stenosis, or it could be acquired causes like TOJ group of infections. And subsequent to that, the patient developed a shunt obstruction for which the shunt was successfully replaced. Currently, the patient, the current status is there's a irritability, there's a fever, there's a tiredness in the patient, and the rectal thermometer, when put, was showing a value of 38.4. Definitely, the child is febrile, and in any patient with the implant in the body. Like in this case, it is a ventriculoperitoneal shunt. I mean, any patient with any implant in the body and there's a presence of fever, I always need to think in terms of an infection. The question says, what is the next best step in the management of this case? So let's look at the options. A says blood culture, definitely makes sense because we're thinking in terms of an infection, and CSF sample by lumbar puncture. Now, my point is that the lumbar puncture of this patient might still be normal because the infection might be limited only to the shunt site. In those circumstances, lumbar puncture per se may not give me an exact picture. So when I read option B, he says blood culture obviously from peripheral blood, but CSF sample by the tap of the ventriculoperitoneal shunt reservoir. This VP shunt goes from behind the ear. The reservoir you can actually see behind the ear, and then it is threaded through the neck into the peritoneal cavity, and this will have a one-way valve. This one-way valve will open whenever the pressure will rise, and it will stabilize the ventricular pressure. So if there's a shunt infection, definitely I can tap the reservoir for getting a good evidence of infection. Option C says do radionuclide scan for functioning of the VP shunt. So a lot of guys actually marked it as C, considering that he had mentioned regarding obstruction. But please appreciate the fact that this is the obstruction of the shunt which had occurred the previous episode, for which the shunt has already been replaced. Currently, he did not mention. I spoke to a large number of students about it. They said the current episode was simply mentioning three things, and these were the words that I've replicated: irritability, tiredness, and a fever documented by rectal thermometer by the nurse to be about 38-39 degrees. So considering any patient having an implant with a fever, we first have to think not in terms of obstruction. In any patient with implant with fever, I have to think first in terms of an infection. So I am ruling out option number C right away because we are not talking about any obstruction in the shunt for the current episode. D will be a very casual statement. I mean, somebody is having an infection. You obviously give paracetamol. You obviously will get TLC for evaluated of the patient to see, I mean, what is the magnitude of leukocytosis. But that will not be a definitive management of the patient. I mean, I need to get rid of the problem per se. So I need to identify the source of infection. I need to demonstrate presence of infection. So option number B is the best possible scenario for this case. Now, obviously, you will say, sir, what's the reference? The reference is definitely from Nelson. In Nelson, he especially mentioned regarding this fact, and I'm zooming it in for you. He says that any case of a shunt malfunction, in fact, this is the main heading. He has described spinal fluid shunts. He has discussed regarding the problems that can occur, colonization, infection, then obviously peritonitis, because the infection will be spread along the CSF to the peritoneal cavity. So obviously, I mean, the two systems are in connection via the shunt, the ventricular system and the peritoneal cavity. So peritonitis can come, and this is what I'll just zoom it in for your convenience. This is what Nelson says: diagnosis by ground stain microscopy, blood culture of the CSF, and the CSF should be obtained by direct aspiration of the shunt. So that's the reference for you guys, because obviously over the public forums, I could not post a reference. I could just say that, okay, this is the answer because of the plausibility that there is an infection present. But then a lot of guys said, sir, what's the reference? The reference is right here before you. The answer to this question is Bombay. We sorted with question number 5 here. Let's move to the next one. The next question talks about a 30-year-old lady who's having a moderate headache thrice a week, for which she was using medication for last 3 consecutive years. So he did not specify what is the cause of headache, but looks like to be a migraine, considering that this lady has been using medication for a fairly long period. And she says a very peculiar statement. She says that in the recent couple of months, I have stopped using the medication and my headache has decreased. I mean, traditionally, whenever we are thinking about any CNS problem, we are rather thinking about that the CNS condition has worsened, so the dosage of medication has to be increased. But this lady has made a very surprising statement. She says, doctor, when I stopped the medication, my headache has decreased. He says, what is the most probable diagnosis? Option A says migraine. Definitely yes, considering the fact that the gender is a female and she is having headache and she is using medication for that long, that looks like a possible diagnosis. But before I say that migraine is the answer, I'm just putting a plus in front of it, plus minus in fact, because I just need to go through the remaining options. Tension type headache. Well, for tension type headache, there will always be a description of a band like constriction around the forehead. Like the patient will say that somebody has rather tied a piece of cloth or a piece of, I would say, or a belt around my forehead and is tightening that piece of cloth or tightening the belt. So that band like constriction per se, that's usually described for tension headache, is not given in this case. And more, I would say, importantly, when it comes to tension headache, there has to be some kind of a stress described per se. It could be a personal problem, a relationship issue, study related issue, but the question does not give any kind of an information per se. When it comes to cluster headache, again, the question does not give any corresponding information, because whenever you read cluster headache, you will always read about a male, that's one, and then he will talk about retroorbital pain or deep-seated boring pain behind the eyeball of the patient, which is not given here. So I'm left between migraine and medication overusage headache. On the casual reading, this might look like migraine, but now you need to be careful about this statement. The question says that her headache has decreased after taking the after stopping the medication. So this is definitely a scenario of a medication overusage headache. In fact, if you go through the discussion on migraine, if you go through the third MCQ, that's what I've highlighted. There's an alternative terminology that is given: analgesic abuse headache. What usually happens is that if a person will overuse painkillers, even that can cause these trigeminal nociceptive receptors to actually, I would say, start firing. They start firing in an abnormal fashion. So the patient perceives the headache relatively more. In fact, it's a very paradoxical statement that I'm saying. I'm saying the nociceptive receptors related to the trigeminal nerve, if you overuse painkillers per se, the overusage of painkillers, especially in migraine, can cause excessive discharge from these receptors, and that can contribute to person saying the fact that doctor, your medication is not working. Please remember the fact this that I'm describing is valid not for triptans, absolutely not for triptans. This is primarily for the usage of painkillers per se. So the alternative term that he used for what is mentioned in the app as analgesic abuse headache, as a third MCQ for migraine, it's gonna be a medication overusage headache in this case. The answer to this question is delta. Coming to the next question, he's talking about an AIDS positive patient who's presenting with fever, cough, and a purulent sputum with difficulty in breathing. So all the markings of a traditional respiratory system question, and he mentioned bronchial breathing in the patient. And the moment you read bronchial breathing, you very well know that you are dealing with a case of pneumonia, and there were some scattered crepitations that were also present, mainly in the inframammary and the infrascapular areas. When the x-ray of the patient was done, my fears were true, in a sense that this person was having a right lower zone consolidation. The CD4 count is a mess. It should be something in the range of 800 to 1200 cells per cubic millimeter. but probably this patient was not compliant with medication, which has resulted in low CD4 count and high probability of opportunistic infections. Now, the first thought process of mine would be any patient with AIDS would be having a pneumocystis jirovecii pneumonia. But the points against jirovecii pneumonia would be primarily the fact that jirovecii pneumonia, the X-ray is usually normal or there are perihilar opacities. You don't read about any specific findings in jirovecii pneumonia. In fact, I want to highlight this fact that the number one cause for pneumonia in an AIDS positive patient is pneumococcus. Why am I saying pneumococcus as an answer to this question? One, because it causes lobar pneumonia and the auscultatory finding of bronchial breathing comes up. And second is the X-ray evidence also given in the question. So both points go in favor of pneumococcal pneumonia. Why it is not zero base? Again, I want to highlight, though CD4 count is lesser, agree to the fact that less CD4 count will obviously predispose to specific organisms. But the point is, when it comes to zero base pneumonia, you need to have rather positive findings in a sense that auscultation wise, you would not be hearing bronchial breathing. And X-ray can be normal or there are perihilar opacities. But in the scenario of per se the exam, I discussed this with a large number of students. This characteristic statement was present, right lower lobe consolidation, which definitely favors a lobar pneumonia due to pneumococcus. And when it comes to tuberculosis, will unlikely to be TB because of a short history. Atypical mycobacteria, yes, mycoplasma could be another cause, but then mycoplasma usually causes crepitations. Mycoplasma to have bronchial breathing is not usually present because mycoplasma is a presentation or causes atypical pneumonia, and all the findings that are given in this case are those of typical pneumonia per se, which give the benefit to diagnosis as pneumococcal pneumonia. I want to highlight once again, overall the number one cause for pneumonia in an AIDS positive patient is not Girovesi. That's a common misconception that we have. The overall most important cause of pneumonia in an AIDS positive patient is pneumococcus. I want to state this fact once again. CD4 count can be supportive evidence. They will never be a diagnostic evidence. I mean, you just can't say that, okay, CD4 count is less than 500, so TB will only occur. I'm saying if the CD4 count is less than 500, what will occur first? First will be pneumococcal pneumonia. Suppose he escapes that, then obviously tuberculosis would come up. So the message is laboratory evidence is never going to be confirmatory of a diagnosis per se. I mean, a lot of guys were adamant about this fact that, doctor, if it's such a low CD4 count, how is it possible for a person to have a pneumococcal pneumonia? In fact, it is rather all the way more plausible for a person with such a dramatically low CD4 count to have higher incidence of a pneumococcal pneumonia. So CD4 count is supportive. Every investigation is supportive. It is the combination of I would say examination findings plus laboratory that makes a diagnosis, and only CD4 counter, only lab report, you just can't comment on the organism per se, because ideally, I mean, how do I know what is the cause? I can do a bronchoalveolar lavage, and if I'm able to find a large number of neutrophils present, I'm able to demonstrate this pneumococcus from gram stain, then definitely that would help me in giving more credibility to my diagnosis. But considering the scenarios given of a lobar pneumonia demonstrated or highlighted two times in the question, one with auscultatory findings, second is the X-ray evidence, the first answer would be pneumococcus for this one. Coming to the next question, he's talking about a 24-year-old gentleman from Chhattisgarh who's having muscle weakness with leg spasm and a gradual onset pure motor paresis. On reading the word pure motor paresis, I'm thinking that could this be a patient who's having Guillain-Barré syndrome, but then the word spasm in the leg, that means increased tone in the leg, goes against the possibility of GBS per se, because GBS has a flaccid paraplegia in all the cases. Option A says vaccine history. Well, vaccine history would be technically acute disseminated encephalomyelitis, and EDEM would at least be having some component of encephalitis. So if this question mentioned about altered sensorium, or it spoke about bizarre behavior, violent behavior of a patient, not recognizing family members, I still could have thought of option number A. Plus, obviously, no vaccine is mentioned in the medical history of this patient. So option number A is, I mean, easily ruled out. Option B says fever history. Yeah, I said, I mean, Guillain-Barré syndrome has to be kept in the possibility, but GBS will be having a rather a flaccid paraplegia. So this I'm writing plus minus because I still have to read the remaining options. C says history of similar complaints in the past. Now you are all aware of a neurological disorder which can be having a relapsing and a remitting course, that is multiple sclerosis. But multiple sclerosis per se is more common in women, no? And multiple sclerosis will also be having optic neuritis. There will be mention of Utto phenomenon where the symptoms tend to worsen on a heat exposure, and none of those informations are given here. So option number A and C are off the radar. We are left between B and D to select. Then you see, when I say diet history, considering the fact that he's talked about a patient from Chhattisgarh, he's probably trying to say a patient from a village, from a less developed state, then he might be actually talking about intake of kesari dal and developmental letharism. Letharism will always be having spasticity, would be having pure motor manifestations, and this person might be requiring even a stick to walk. So the bottom line is, when you consider option number B versus D, I would give more credibility to option number D. Diet history is of paramount importance for solving this question, considering low socioeconomic status, which is highlighted by the background of the patient and the keyword. I mean, I am not simply, I would say, basing my diagnosis on the origin of the patient. No, I'm not basing my diagnosis on the basis of the state of origin of the patient. I am basing my diagnosis on the basis of this word. I mean, why is it not GBS? Why it is not transverse myelitis? Because both would be having flaccid manifestations. I mean, in both the scenarios, you always read about lower motor neuron manifestations occurring in a patient, which has ruled out option number beta. And both GBS and transverse myelitis can be having a antecedental history of a respiratory tract infection or a diarrhea in a person, which are obviously caused by viruses. So when you go back in the retrospective and you talk to patients of GBS or transverse myelitis, they definitely talk about presence of fever also. I put a plus minus to say yes, it could have been a possibility, but the clinical finding of hypertonia slash leg spasm is ruling out option number B. The answer to this correct question, the correct option is delta. The subsequent question talks about an elderly diabetic female who's presented with multiple episodes of vomiting. The moment you read a diabetic patient, you think in terms of diabetic ketoacidosis or a non-ketotic hyperosmolar coma, but the question says vomiting in the patient, and vomiting always implies there is some dehydration, and this will contribute to activation of the RAS system, and vomiting will be associated with metabolic alkalosis. Let us now see what the ABG tells us. The BP of this lady is on the lower side. That could be primarily explained by the dehydration component, loss of body fluids, and the pH of the patient is 7.5. So pH is definitely increased. I have deduced that this person is having alkalosis on the basis of ABG. Now PCO2 of the patient is 45, that is on the upper limit of normal. So it's unlikely to be a respiratory problem, because for respiratory problem carbon dioxide should be lesser. Respiratory alkalosis occurs when carbon dioxide is lesser. Respiratory acidosis occurs when carbon dioxide is more. In this patient, carbon dioxide is upper limit of normal, so unlikely to be a respiratory component. But yeah, the bicarbonate of the patient is definitely low. So I am highlighting the fact that why am I saying that this patient's ABG shows a confirmed metabolic alkalosis of the uncompensated variety, because the bicarbonate of this patient is definitely elevated. Normal is 22 to 26. This is 30. And at the same time, the carbon dioxide values have not, in this particular case, increased. They are on the upper limit of normal. So at the moment, it is still uncompensated. The question says comment on the etiology of these findings. Then renal tubular acidosis is anyway ruled out, because we're not talking about any scleroderma, we're not talking about any kidney stones per se. Diabetic ketoacidosis was my first thought process. I ruled it out on the basis of both the clinical findings as well as the pH of the patient. So he simply says what is responsible for this metabolic alkalosis. It is protracted vomiting and septic shock. Yes, if there's a shock, then shock again causes development of acidosis. I mean, in fact, septic shock will cause lactate production, that will cause pH of the patient to decrease, is the reason. I mean, I have ruled out option number delta primarily because if there's going to be lactate overproduction in septic shock, then it will cause metabolic acidosis. The correct answer to this question is option number C. I would rate it as an easy one. Why? Because he did not even ask you about the compensation versus uncompensated scenarios, partially compensated versus fully compensated scenarios, but he simply said what is the etiology behind this ABG changes, and that would be protected vomiting. The next question talks about pheochromocytoma, and he says what is false. So you need to be very careful, because the moment the question comes to the other way around, what I mean by other way around would be that in the negative sense he's asking you, then you need to be a little careful, because normally when we attempt questions, we are in that mood of all except varieties. A says propranolol is used first line for hypertension control. Now for pheochromocytoma, we first give alpha blocker, then we give beta blocker. Alpha blocker will neutralize the vasoconstriction, and the beta blocker will take care of the tremors, and it will also take care of the excessive sympathomimetic stimulation that is occurring in these patients. The problem is that if you will not give alpha blocker and if you will give only beta blocker, then the problem would be that beta is responsible for vasodilation. In fact, this is how I have explained it. I've said the management of pheo is alpha plus beta. Beta plus alpha is contraindicated because the moment you will give beta to the patient, first, you will cut off the vasodilatory component. If you cut off the vasodilatory component from the body, then the alpha activity will be unopposed. I repeat the fact once again. If you give beta blocker to this patient as first thing in the morning, the alpha activity in this patient will be unopposed. The BP will spike. You can end up with development of hypertensive crisis, which is definitely not warranted. So definitely option number A looks like the answer to this question, in a sense that this is the wrong statement. B says surgery is the treatment of choice. Obviously, we are having a tumor originating from the adrenal medulla. So I will try to manage it medically, but ultimately as the tumor will keep on increasing, it can produce a mass effect as well. So the definitive treatment for a benign pheochromocytoma is definitely surgery, because 90% of these tumors are benign. You see, if it is a malignant pheochromocytoma, we will have to give chemotherapy, but because majority of pheochromocytomas are benign, therefore surgery is the best treatment for these patients. So I would say that option number B is not 100% correct, but it is 90% correct based on the evidence that I've highlighted before you. I mean, that's the statement that's given in the textbook, and I have just repeated that before you. 90% of pheos are benign, so definitive treatment surgery. That's a correct statement. I'm just putting alphabet C before it. C says urinary catecholamines are used. Yes, ideally we should be using urinary metanephrines, but urinary catecholamines can also be used provided you have good testing facilities. And patients will anyway be having hypertension with nausea, vomiting, abdominal discomfort can definitely be present in this patient. So C and D definitely are correct statements. B is partially correct. So between A and B, the correct answer to this question is option number alpha. As I highlighted, I mean, in this particular chap, the unopposed vasoconstriction, if you use only a beta blocker, will contribute to hypertensive crisis of this patient. Therefore, the answer to this question is alpha. The subsequent question talks about a 50-year-old patient with nocturnal cough, breathlessness, and wheezing episodes. When I read about this, I'm thinking this could be probably related to asthma. Absolute eosinophil count of the patient is 5,000. Normal values were not given. They are in the range of 40 to 400. That I put it only for your convenience. But I definitely know that in this particular chap, if the eosinophil count is spiking this high, either it could be a parasitic infestation or it could be an asthmatic manifestation. And the X-ray shows miliary pattern. Now, when it comes to bronchial asthma, I mean, I'm ruling out bronchial asthma in this case because in asthma, when you run a chest X-ray, the X-ray will either be normal in majority of cases, and if you are going to do an X-ray in an asthmatic patient during an exacerbation or worsening, it will show flattening of the diaphragm, it will show evidence of hyperinflation, but never in asthma will you be having miliary pattern. Another reason why this is unlikely to be asthma is because in adult onset asthma, you will read about intrinsic and extrinsic asthma, pediatric onset versus adult onset asthma. It is the pediatric onset asthma that has increased eosinophil count. The adult onset asthma usually has normal eosinophil count. I repeat the fact once again, eosinophilia is what you encounter with respect to the pediatric onset asthma. In adult onset asthma, rather eosinophil count is normal. That's again a point going against asthma, because in our MCQ, eosinophil count is just spiking through the roof. It is 10 times of normal. Miliary tuberculosis, well, there is no evidence of any, I would say, immunocompromised state. Any decreased cell-mediated immunity is not given in this question. So that's why A is off the radar. We are left between B and D. Hypersensitivity pneumonitis should be having some kind of an occupational history available, like with respect to Barger-Swiss's or bisonosis, there should be some industrial exposure or some kind of occupational history given in the case. Since there is none given, I'm ruling out option number D as well. The correct diagnosis of this chap with Ideally, the word in the question should have been fleeting pulmonary opacities. But had he put that word fleeting pulmonary opacities right away, that would have been a piece of cake for you. So he rather put up the word miliary pattern, but that implies the same, that these are whitish spots that are seen all over, and you very well know the reason. Tropical pulmonary eosinophilia is mainly caused by worms migrating through the lungs. If he says which one, just like you're comfortable with the fact that Loeffler syndrome is due to migration or scariasis through the lungs, in tropical pulmonary eosinophilia, it's microfilaria that are migrating to the lungs, and therefore this picture suits tropical pulmonary eosinophilia primarily. Coming to the next question, he talked about a patient with breathlessness, easy fatigue, and peripheral edema. There was a mid-diastolic murmur with a giant slash steep A wave in the JVP. So the moment you read about a steep or large A wave, you basically know that the right atria is having to work against a resistance. The causes for giant A waves or steep A waves would be tricuspid stenosis, mitral stenosis, as well as pulmonary artery hypertension in a patient. Now, my point is that when it comes to mitral stenosis, it will take some time for the mitral stenosis to cause development of right-sided heart problem, because per se mitral stenosis is a disease of the left. But whenever there is a long-standing mitral stenosis, only then the pulmonary venous hypertension is followed by pulmonary artery hypertension, and that is when a giant A wave would be produced. So option number A versus option number B, tricuspid stenosis, definitely looks more promising. Another hint in the question, though some people disputed this statement, they said, sir, this initial statement was not given in the exam. I mean, a lot of guys said, sir, there was no breathlessness or easy fatigability given in the question. And in fact, those, a lot of them who read this statement, they said, sir, we thought mitral stenosis is more common than tricuspid stenosis, so that's why we marked mitral stenosis. My point is, when you read about peripheral edema in a question, peripheral edema first should be thought of as right ventricular decompensation, and right ventricular decompensation would be occurring with respect to tricuspid stenosis. I agree to the fact that we can go the entire day debating about it, but the bottom line is mitral stenosis long standing would contribute to a large wave, and that's the statement that I've said even when the word steep A wave has been discussed in the app, or whenever I've discussed about JVP, I have first written tricuspid stenosis than mitral stenosis. I agree to the fact that mitral stenosis as a valvular lesion is more common than tricuspid stenosis. No issue of, debate on that. My point is just focus on the word steep A wave and also focus on peripheral edema in a patient. Both give credibility to option number A, tricuspid stenosis, as a diagnosis for this one. The subsequent question talked about a 25-year-old patient with mitral stenosis with irregular pulse who's presented to the OPD. So the moment you read irregular pulse, you know we are talking about atrial fibrillation. There's a pulse deficit of more than 10. Pulse deficit basically means that the heart rate and the pulse rate will not match. You see, in you and me, the heart rate and the pulse rate will always be same. If your heart is doing 75 times per minute, your pulse rate will also be 75. But if heart rate and pulse rate never ever match, the reason for that is in atrial fibrillation, because rhythm is not regular. The two beats might occur so close together that you may actually count them as one. I repeat the fact once again, because there's an irregular pulse. So the two beats of the pulse that occur may occur so close together that you might actually read them as one or may feel them as one. So therefore, if you count two beats as one, obviously both the heart rate and the pulse rate will not match. The heart is beating, but the two pulses, two separate independent pulse waveforms were read as one by you. So pulse deficit is implying the fact that this is atrial fibrillation. Echo of the patient is normal and shows no thrombi. Now, I want to highlight the fact that at the moment there are no thrombi. That does not mean they will not occur after 1 day or after 6 hours or after 12 hours. Point number one. Second, the echo that is usually done in our hospitals is transthoracic echocardiography. Ideally, you should be doing a transesophageal echocardiography to identify the thrombi in the left atrial appendage. There is also another scenario that the thrombi might be very small in size at the moment, so they are in the process of formation and may not be visualized at the moment. I said a lot of things, so I want to repeat this fact. One, echocardiography, the traditional one, transthoracic, may not be able to pick up the clots in the left atrial appendage. Another possibility is clots are not present at the moment. They might develop the next day or the next day. So just today echo is normal does not mean that I deny treatment for somebody. More importantly, if the clots are of small size, they are present, but they're not getting visualized. The problem is you as an operator are not able to pick them up. They're already present. So I definitely would like to give protection to the patient, because I very well know my patient will end up with development of embolic stroke. That means aggressive anticoagulation should be used in this patient. Now, this question is rather a direct lift off from the NEET exam that was conducted 1 month before the NEET PG. You see, the bottom line is if somebody is having mitral stenosis, in those circumstances, the incidence of embolic stroke is already very high. So we do not use novel oral anticoagulants. I've discussed this even in the NEET part, so I request you to go to the initial part of the NEET paper and listen to the fact that if a person with mitral stenosis is in atrial fibrillation, because these patients are having high incidence or development of stroke per se, we do not use novel oral anticoagulants in patients who are having a valvular lesion or having a prosthetic valve in place. Aspirin plus clopidogrel. Well, aspirin plus clopidogrel is dual antiplatelet therapy. Dual antiplatelet therapy is usually given in acute coronary syndrome. Dual antiplatelet therapy is given after transient ischemic attack. It is given after post stenting, like a person underwent a coronary artery stent or underwent a CABG. That's when dual antiplatelet therapy is given. So I wanna, in this particular case, reduce the incidence of embolic stroke by giving warfarin to the patient. Well, why not heparin? Because it will be a lot of inconvenience. Now, to give a subcutaneous shot on a regular basis, warfarin will be, I would say, a much more suitable option from the patient's perspective as compared to getting an injection every day. Between the two close options, A versus C, why A is not given is because dabigatran or NOAC or direct acting anticoagulants or novel oral acting anticoagulants, they are not recommended. I'm just putting across here, they're not recommended in patients who are having valvular atrial fibrillation with respect to rheumatic heart disease. If they're having a non-valvular atrial fibrillation, like somebody is having dilated cardiomyopathy and he's having atrial fibrillation, fine, you can use dabigatran, you can use apixaban, you can use rivaroxaban. If it's a non-valvular atrial fibrillation, cool, no problems. But in a valvular atrial fibrillation, which is secondary to rheumatic etiology, we do not use novel oral anticoagulants. And well, the reference from Harrison is anywhere present. I mean, since the question mentioned mitral valve disease, atrial fibrillation, it is oral anticoagulants which are recommended. In the subsequent MCQ, he talks about a CKD patient landing in uremic encephalopathy. You very well know that any patient having CKD, there is going to be an impaired hydrogen excretion, and that will explain the metabolic acidosis component that would be encountered in these patients, and that helps me rule out option number B and D because both of them are in alkalotic range. Selection between A and B would be relatively simple in a sense that when I look at option number A, you will see that there is definitely acidosis. And then in any patient having acidosis, I need to work out whether there's a metabolic problem or a respiratory problem. In respiratory problem, carbon dioxide is elevated, but in this MCQ, you can notice carbon dioxide is on the lower side, so it cannot be a respiratory problem. There is definitely a metabolic component which is present here. And if you look at the direction of arrows here, you can see all the three things, the pH, the PCO2 and the bicarbonate, all are going in same direction, which is very, very characteristic for metabolic acidosis. I also want to highlight that when you look at option number C, carbon dioxide is elevated, and that's a very characteristic feature that you see with respiratory acidosis per se. And just I'll spend a few seconds extra here by mentioning that because in option number C, the bicarbonate values are normal. That's a range of 22 to 26 because they're within normal limits. So that means that the kidney has not kicked in the compensation. So in option number C, patient is having uncompensated respiratory acidosis. Though we have worked out the answer to this question, I would still like to check out whether this patient is having a compensation process going in for him or not. So you need to remember the fact that for working out the compensation of metabolic acidosis, which is going to be respiratory alpha losses, you just need to check out the expected PCO2 of the patient. What you will do is that whatever is the actual bicarbonate value which is given in the question, you just need to add 15 to it. Now, if you add the value of bicarbonate, which is 9 plus 15, that will work out to approximately about 24. So bicarbonate of the actual is to be considered, and the carbon dioxide value is coming pretty close to what you have calculated. So that means the fact that the compensation process is going on at the movement, and this patient is having I would say, and that in fact that's very much documented even by the fact that carbon dioxide is lesser. If carbon dioxide is lesser, that means the guy is breathing faster. I mean, that's what happens in respiratory alkalosis. No, there's a carbon dioxide washout in this patient. So compensation process is definitely kicked in. Though in the exam, he actually did not get into these technical details and did not ask about the compensation process per se. The answer to this question is option number alpha. Coming to the next question, we are talking about a 24-year-old software professional with complaints of weakness and easy fatigability since 1 month. And mostly in the lockdown period, I mean, people are working from home and they're rather putting in extra hours to meet the company deadline. So this lady, she's working about 14 hours per day, and she's eating a lot of junk food, fast food, and her diet is lacking fruits and vegetables, and she's definitely having a MCV which is elevated. So we are sure this is macrocytic anemia. Either it's going to be B12 deficiency or it's going to be folic acid deficiency. There are two ways to crack this question. One, you need to remember my statement that folic acid deficiency can occur as early as about 3 months, whereas when it comes to vitamin B12 deficiency, it will take a huge number of years for it to manifest. So what I can say is that in this particular case, since this person is having problems since last 1 to 2 months only, the probability of folic acid deficiency will be higher as compared to that of B12 deficiency. Second aspect to be understood is that vitamin B12 is mainly present in food products which are derived from animal sources. Now, if somebody is, let me say, eating junk food, like somebody is eating chicken burger, so at least if a person is eating animal derived foods, or even if a person is eating cheese, you see, cheese is after all, for you and me, vegetarian stuff, but for people who are hardcore vegans, they do not take even cheese and milk and curd and stuff like that. So they are the ones who would be susceptible to vitamin B12 deficiency. I mean, people who do not take animal source derived foods. But in our case, our patient is not taking only fruits and vegetables, which makes it the patient being suffering from a folic acid deficiency. I said there are two ways to crack this question. One will be with respect to how long will it take for the manifestations of deficiency to appear. So the message number one for this MCQ is folic acid deficiency appears earlier as compared to vitamin B12 deficiency. And since in this question shorter history is given, so that's why I said folic acid deficiency. Point number two is that because the person is at least eating fast food, that means patient would be eating at least chicken burger or something related to animal source per se. That could be even cheese or processed foods as well. So patient is unlikely to have a vitamin B12 deficiency. Rather, I would say lack of fruits and vegetables in the diet in a short duration makes it a folic acid deficiency as a probable scenario. Coming to the next question, he talks about a patient of chronic renal insufficiency who is presenting with peripheral edema. So the patient is having puffy eyes, puffy feet, and for this, obviously, I would like to mobilize this edema fluid per se, because person may not be able to wear his slippers properly. There's anyway an oliguria, which is a standard feature in all patients with CKD, and he says what drug will be suited for management of high renin hypertension. I double checked with a lot of students. This word was given, high renin hypertension, which was deliberately a ploy on the part of the examiner to make us think in terms of aliskiren. Aliskiren, guys, is not given in patients of renal insufficiency, mainly because of the risk of hyperkalemia. And I have a Goodman-Gilman reference here. It mentions the fact that aliskiren, the direct renin inhibitor, I mean, it looks like a very good option available. But then I have just zoomed in for you. It mentions that this is not given in diabetic nephropathy or in patients of renal insufficiency, and primarily the risk is that related to the predominant hyperkalemia component that can develop in these patients. So point number A, though looks very enticing and looks a very, I would say, attractive option, goes out of the picture primarily because of the reference that I mentioned. Option number B, chlorthalidone. Yes, this definitely looks like one of the drugs that would be used. I know hyperuricemia will be a big time side effect with this drug, but considering the edema scenario and the initial presentation of CKD, I can definitely use diuretics. This particular NEET exam, they had mentioned regarding CKD patient with peripheral edema, but in the Set exam, which was conducted just one and a half month before the NEET exam, they had given the scenario of a CKD patient with EGFR less than 30 ml per minute. In that Set discussion, I have mentioned and given reference of Harrison, and I mentioned that Harrison mentions metazolone to be useful for management of these patients. So we don't use chlorthalidone in case the GFR of the patient is less than 30. If the patient is having end stage renal disease, in those circumstances, you already have tried all the earlier options, and then you would be using an alpha blocker or a beta blocker for this particular patient, with alpha blocker coming in first. between the two options, that is chlorthalidone and prazosin, all I want to say is that prazosin is what is going to be recommended mainly in case of ESRD. And I double checked with a lot of students, they highlighted this fact that end stage renal disease as a word was not given. In fact, there was no hint also suggestive of end stage renal disease. There was no anemia documented, there was no hyperphosphatemia, there was no calcification of blood vessels, no uremic complications documented in the patient. They characteristically mentioned edema and puffiness, or findings suggestive of a bloated patient. So in initial stages of CKD, we definitely can be using chlorthalidone for the patient, and I'm going to show you reference here as well. This is the ESC, the European Society of Cardiology guidelines, which mention that initially you can be using ACE inhibitor or ARB along with calcium channel blocker for the patient. A lot of guys also said that instead of beta blocker, it was calcium channel blocker. Now, I just want to highlight that calcium channel blocker per se will worsen the peripheral edema of the patient. So, I did not keep CCB in one of the options of the MCQ, but even if it was present, it is still not the answer. Why? Because calcium channel blockers anyway cause ankle edema. So in initial stages of the patient, I definitely can be using A plus C, but then he says diuretics in all the stages. It's only subsequently when you start getting resistant hypertension, when you progress towards a grade 4, grade 5 CKD, that's where alpha blockers come in the picture. And beta blockers is also mentioned for specific scenarios. Like if I just zoom it in, he says patient with heart failure, patient with angina. I mean, anytime you're having an associated cardiovascular morbidity associated, then you can be using beta blockers for the patient. Considering the controversy related to this question, I just want to highlight that in a person of CKD grade 1, grade 2 initially, if there is a edema present, we definitely can be using thiazide group of diuretics, that is chlorthiazide for these patients. But if he mentions EGFR less than 30, then the answer should be switched over to metazolone. If he mentions ESRD, which I highlight once again, was not given, no evidence of ESRD was given in the question. Though if it is, no issues, then you answer alpha blocker. In our clinical practice also, in our patients of grade 4, grade 5 CKD, we use alpha blockers, and I've just shown you the ESC reference for the same as well. But the question mentioned the initial presentation of the disease. This is the snapshot of the NEET question that I've discussed, so I thought I'll just include this in this discussion as well. I'll just read out the question before you. The question said hypertensive patient grade 4 CKD with EGFR less than 30. The doctor wants to prescribe a thiazide diuretic. So this again proves if any set people have themselves written thiazide diuretic, he's asking you to select one, and that's where metazolone has been answered. And I have explained that even with respect to cardiorenal syndrome, which is a topic which is not in the app because it's a very small one, and you can find cardiorenal syndrome on the YouTube channel of mine. And if you go through that, I've talked about specifically role of metazolone in CKD patients. Coming to the subsequent question, there was this 16-year-old boy who's having low back pain with morning stiffness. So the moment you read about morning stiffness coming up, back pain in a young chap boy, we think in terms of HLA-B27 positivity, ankylosing spondylitis. The question mentions is having bilateral heel pain. This is enthesopathy. If you go through the video of ankylosing spondylitis, I've used this term a couple of times, enthesiitis or enthesopathy, that means heel pain, and his eyes are always looking red. We very well know the fact that patients of ankylosing spondylitis would be having extra articular manifestation as well. In fact, a lot of these patients could be having uveitis component present. So, I mean, eyes looking red is mainly mentioning or pointing towards the extra articular manifestations of the disease. Option A says mechanical low back pain. I mean, this guy, there's no description that he slouches on a chair and plays video games for long hours, or like he studies for long hours. I mean, mechanical back pain is what you and me can get because we keep on sitting on a chair for a very long duration handling our patients. But ankylosing spondylitis definitely looks like a promising answer to this one. There's no history suggestive of tuberculosis per se. There's no weight loss, no cachexia, no fever described in the question. So unlikely. And disc prolapse again would cause neuropathic pain, but there would be no heel pain and there would be no extra articular manifestations like red eyes mentioned in upper left intervertebral disc. So the best answer to this question is option number Bombay. The next question talks about a patient with vomiting and the doctor gave antiemetic. So most of the time perinom would have been given. That's usually commonly available in our government hospitals, metoclopramide. And the biggest side effect of that would be that it will contribute to imbalance between dopamine and acetylcholine. In fact, the patient has developed motor symptoms. What we commonly see in our hospital casualties, extrapyramidal syndrome. I mean, we commonly see dystonia developing in these patients, or I can just say the casually the word drug-induced Parkinsonism. So if a person is given perinom metoclopramide and there's an imbalance, I will not try to increase the dopamine. I will not try to increase dopamine. Rather, I will try to neutralize this increased acetylcholine by giving an anticholinergic drug to the patient. So benzexol will help in restoring the balance between these transmitters, and the EPS or the extrapyramidal syndrome manifestations will be curtailed. In the next one, there's a 65-year-old person who feels tired towards the end of the day and symptoms reduce with rest. So the question is beginning by describing diurnal variation, and whenever you read about a question that talks about weakness or neurological symptoms with diurnal variation, you are thinking in terms of myasthenia gravis, or it could be Lambert-Eaton syndrome, considering the age of the patient and first thinking in terms of Lambert-Eaton. On examination, there's a ptosis and a difficulty in mastication noticed on sustained use of muscles. So he is basically talking about a decremental response, and the movement assay diurnal variation of weakness. The movement assay the word decremental response. You very well know that the diagnosis of yours would be myasthenia gravis. You see, Lambert-Eaton syndrome per se will always be having incremental findings, or I would say incremental response that would be documented on single fiber electromyography. In fact, these patients will tend to feel better after repeated activity. In myasthenia gravis, when the person will perform the activity, by the end of the day, he will say, I'm dead tired. In contrast, Lambert-Eaton syndrome patient will be, I would say, on repeated activity, he will start feeling relatively better. When I say repeated activity, makes the person feel better, I mean incremental response, which is very characteristic. And Lambert-Eaton syndrome is anyway associated with malignancies, and there's no associated malignancy which is given in this question. So yes, myasthenia gravis is common in younger females, but in older age group it is more common in male patients. The next question talks about a 35-year-old lady with temporal headache and arm claudication. Now the moment I read about arm claudication per se, I am always thinking in terms of Takayasu as a possibility, because that's a very standard presentation. We very well know that in Takayasu's arteritis, left subclavian artery ostia is involved. Takayasu has a possibility of causing ostial narrowing, and that explains the arm claudication fact. And even femoral pulses which are weak are noted. So we very well know that Takayasu's arteritis is also called as pulseless disease. If you look at the last line of this MCQ, he says fundus examination shows retinal hemorrhages. We need to dissect why that is happening. In Takayasu's arteritis, not only can you be having narrowing of the subclavian artery ostia, but you can also be having narrowing of the ostia of the renal artery. So if there's going to be renal artery stenosis also developing in this patient's, hypertension will occur, and this hypertension can definitely explain development of flame-shaped hemorrhages that can be seen on a fundus examination of the patient. So when you look at the question in totality, 3 points given here: arm claudication. Why? Because there is narrowing of the ostia of the subclavian artery. There is weak femoral pulses. Anyway, the distal circulation is affected. Even the aorta can be involved in these patients, and the pulseless disease is a technical term for it. And then lastly, I said RAS activation would contribute to hypertension, and a fundus showing a retinal hemorrhages as well. If you look at option number A, polyarteritis nodosa. Now, polyarteritis nodosa does not have weak femoral pulses, so I'm ruling that out, because mostly polyarteritis nodosa question will talk about kidney involvement in a patient. It will talk about kidney involvement without a glomerulonephritis. So there is mostly a description of hematuria with hypertension. Thrombojatus obliterans would be common in a cigarette smoker, and he will talk about intermittent claudication. He will talk about patient developing pain, especially in the feet or in the legs, whereas in our case, the pain is given in the arms. So again, thrombojatus obliterans becomes unlikely. Microscopic polyangiitis again will be having a kidney involvement primarily. So by exclusion also, you can work out to the diagnosis of this patient per se as Takayasu's arteritis. 3 things are said: subclavian artery narrowing, renal artery ostial narrowing, and at the same time, the pan-arteritis component can contribute to a pulseless disease presentation. The next question talks about a 50-year-old alcoholic with a drinking history of 20 years, comes with jaundice, yellow sclera, abdominal distension, and a decreased urine output. Well, what I'm seeing in this case is a standard presentation of decompensated cirrhosis. Why am I saying Decompensated cirrhosis is primarily because in cirrhosis usually you don't see presence of any jaundice, but our patient is having jaundice, he's also having ascites. That's a pointer towards presence of decompensation. And the key word of this question was decreased urine output, which means that this ascites patient has gone into hepatorenal syndrome. Let's get the facts together. He first became an alcoholic cirrhotic patient. Alcoholic cirrhosis resulted in ascites, and in ascites, because there is third space loss, there is wastage of fluid in the peritoneal cavity, so the perfusion of the kidney is affected. And if the blood supply of the kidney is affected, these patients would be having is a development of pre-renal variety of acute kidney injury. Therefore, for management of these patients, I need to ensure that the perfusion of the kidney becomes relatively better. If you look at propranolol, propranolol is always used in patients of portal hypertension. Yes, we are talking about portal hypertension, we are talking about a cirrhotic patient, but then propranolol is mainly used for prevention of development of bleeding from the esophageal varices, but we don't study about role of propranolol in hepatorenal syndrome. That's the problem of our patient decreased urinary output. So propranolol will not do anything to rather improve hepatorenal syndrome or improve the kidney perfusion. It's primarily used to prevent the development of esophageal varices per se. So this is off the radar. If I say saline infusion, yes, I mean that definitely makes sense. I would like to perfuse my patient better so that I can make a diagnosis of hepatorenal syndrome. So saline infusion is definitely in. But when it comes to torsemide, I'm just saying plus minus here for option number C, but definitely not torsemide, because we don't give a bolus shot of diuretic in an established renal failure. You see, whenever you are having AKI, you are supposed to give a infusion. You're always supposed to give it in a drip format. You never give a bolus shot of torsemide. And if I give torsemide to a guy who's already gone into renal failure or person hepatorenal syndrome, it's not gonna cause too much of a difference for, I would say, the survival or reduction in mortality or reduction in symptoms of the patient. I'm left between two options. It is either octreotide plus albumin or it's going to be saline infusion. You see, we for hepatorenal syndrome to be diagnosed definitely need to give a saline infusion to ensure good perfusion of the kidney. So that at least when you ensure good perfusion of the kidneys, you are able to document the fact that yes, this is hepatorenal syndrome. But the question said, what is the optimal step for the management of this patient? So first and foremost, what I need to do in this chap is to improve the blood supply to the kidney. I can give IV albumin. If I will give IV albumin, let us just see what albumin will do. If I administer IV albumin to any guy in hepatorenal syndrome, it will increase the oncotic pressure. Yes. This increase of oncotic pressure will cause mobilization of fluid. Listen to my words very carefully. It will cause mobilization of the fluids from the peritoneal cavity. There was wastage of fluid in the peritoneal cavity, right? Ascites. So there is going to be mobilization of fluid from the peritoneal cavity into the intravascular compartment. And when I send the fluid back into the intravascular compartment, it means the fact that now the perfusion of the kidney will improve. So we can give albumin in patients who are having hepatorenal or progressing towards hepatorenal syndrome simply to enhance the renal perfusion. Similarly, octreotide also improves. There are two drugs which can be used in hepatorenal syndrome. It is midodrine or it is octreotide. Both of them would be vasopressors and they improve the perfusion of the kidney per se. And well, it's not that I am saying it, it's what the textbook also says, that in management of hepatorenal syndrome, we are supposed to give albumin to the patient. I explained the reason. It will get the fluid back into the intravascular compartment, so the kidney perfusion will improve. And the drugs which can be used are terlipressin, or we can use midodrine, or we can use octreotide in the patient. The advantage will be that they will again improve the renal perfusion per se. And for diagnosis of hepatorenal syndrome, please appreciate the fact, if this question said what is the next best test for initial diagnosis of hepatorenal syndrome, then initially we give saline infusion to ensure that hypovolemia is not the reason. You see, one of the important reasons of pre-renal variety of acute kidney injury is underperfusion of the kidney due to hypovolemia. So in the main lecture of hepatorenal syndrome, when you listen to my discussion, I have highlighted that when you need to demonstrate hepatorenal syndrome, you initially give a fluid challenge to the patient. This fluid bolus of fluid channel will help you in diagnosis of hepatorenal syndrome, but it will not help you in definitive treatment per se. In this question per se, the essence of the question was, what is the intervention that you would be doing for the patient per se? So I checked with my students, this was not for the diagnosis. If this question was, what is the best way to establish the diagnosis of this patient, initial step for establishing the diagnosis, yeah, I will say option number C. That's why I put a plus minus. But the question was not towards establishing a diagnosis. The question was very much treatment oriented question. That was the language. He said, what do you do for a management of a patient of hepatorenal syndrome? So you're going to give albumin to the patient so that you can ensure perfusion. Vasoconstrictors definitely will work. Midodrain will work. Octreotide will work for these patients. And you would be trying to save the kidneys, because ultimately kidney is not at fault. It's the liver that is fault, and definitive treatment of hepatorenal syndrome is obviously a orthoptic liver transplantation, but that OLT would be a second step. Initially, we need to stabilize the patient per se and bring down the serum creatinine values. The subsequent question is pediatric/medicine. This talked about a 10-year-old child with recurrent pulmonary infections is having recurrent bulky stools with a fat to the tune of 10 grams. Now that's pretty substantial. So one, I'm having recurrent pulmonary infections. I'm also having steatorrhea. And both of these point towards that this kid could be having mucoviscidosis, child could be having cystic fibrosis. Now this question has been widely debated on social media. So I thought I'll just show you a couple of references for the question per se, option wise. Option A said serum shows hypernatremia. Now this is what Nelson says, that children with cystic fibrosis would be having increased sodium losses from the skin. So when I say sodium losses from the skin, I repeat the fact, if I lose sodium from the skin, it will cause a hyponatremia. That's why I'm ruling out option number A in this case, in a sense that serum would be showing hyponatremia, not a hypernatremia. B says child has protein losing enteropathy. This was the initial answer that was given for this question. Let's look at the reasons behind development of protein losing enteropathy. In the textbook for causes of enteropathy, there are three reasons that are given. He says either it could be inflammatory cause. Inflammatory could be, for example, pseudomembranous colitis, cytomegalovirus, NSAIDs, post chemotherapy. Or he says it could be lymphatic obstruction like intestinal lymphangiectasia, where the lymphatic channels are not developed properly. Or it could be increased permeability of the mucosa of the gut, like in tropical sprue, celiac sprue, or Menetrius disease per se. There is no mention of cystic fibrosis in the entire table with respect to protein losing enteropathy. What is protein losing enteropathy? There is loss of protein in GI secretions. Why it occurs? There can be three reasons. I said it could be inflammatory, like it could be infection, like pseudomembranous colitis, cytomegalovirus infection, lymphatic obstruction, increased permeability. Cystic fibrosis does not fit into any of the three because that's a disease of the exocrine glands per se. It's a problem with the pancreatic secretions. It is problem with secretions of the exocrine gland per se. So option number B, guys, does not make sense, and I've shown you a reference. I mean, CF is not given in the table of protein losing enteropathy. We are left with in rectal prolapse may occur in patient has distal intestinal obstruction at this age. I'm going to show you a reference from Harrison which mentions the fact that in older individuals with cystic fibrosis, there is a distal intestinal obstructive syndrome. When it comes to option number C, it was mentioned, in fact, I'll just modify this option right here before you, and do correct me for this. It mentioned rectal prolapse may occur in spite of treatment. I mean, this is what I have seen in other discussions also, that they have used this word rectal prolapse may occur in spite of treatment. First of all, let us understand why rectal prolapse, because this child will develop malabsorption. Malabsorptive kids would be having loss of subcutaneous fat, so fat all over the body would be lost, and the rectal pad of fat would also be lost. So every time child will defecate, something will come out, and that would be the rectum. What the mother is saying something, that is the rectum of the child that is coming out. So rectal prolapse occurs in protein energy malnutrition. Usually it occurs in smaller children between 1 to 3 years of age. We usually don't see rectal prolapse at 10 years of age. Second, rectal prolapse, I have modified this. I mean, even if I have not modified it, even then option number C does not make sense. Why? Because rectal prolapse is seen in younger patients with malabsorption, with malnutrition per se. To have rectal prolapse at 10 years, very, very unlikely, unless and until it's going to be gross anatomical abnormality, it's unlikely. And then some people said in option number C, it was written rectal prolapse may occur in spite of treatment. So if you're going to treat a person with cystic fibrosis with IVA catheter or supplements of pancreatic enzymes, with treatment, malabsorption will definitely be taken care of. The malnutrition component will be taken care of. And if you take care of malnutrition, rectal prolapse will not occur. But what is mentioned in Harrison very characteristically is a distant intestinal obstruction. The correct answer for this question is option number delta. I know this was widely debated, but I've given references for each of the options here. So anyway, the PDF would be available of this, so you can go through. I mean, I've given reference for Nelson for sodium losses. I've given you a table for protein losing enteropathy per se. So I mean, we definitely, and a Harrison reference for distal intestinal obstruction. So 3 references in a single question should definitely be satisfying you. Coming to the next question, he talks about a male patient who's having weak femoral pulses with an upper limb BP of 180/90. So basically the question is talking about inequality between blood pressure. That is, upper limb blood pressure of the patient is grossly elevated as compared to the lower limb, which tells you that there's some narrowing of the aorta definitely. He also mentions about increased pulsations of the intercostal arteries. These pulsations of intercostal arteries is because they're behaving like collaterals in a patient of coarctation of aorta. You very well know that in coarctation of aorta, which is usually present distal to the origin of the left subclavian artery, blood supply to the lower limbs is lesser. But upper limb BP will always be relatively increased. And this keyword pulsations of intercostal arteries, that's the standard presentation that if you look at the back of the patient just below the scapula, you can notice pulsations of the intercostal arteries and sometimes even between the ribs as well, provided person does not have substantial fat in the chest. The correct diagnosis of this question is beta. I'm ruling out Takayasu's arteritis because Takayasu's arteritis would rather be having an unequal BP between left and right arm. In Takayasu's arteritis, because the left subclavian artery is the one that is commonly involved, so the statement of mine is unequal BP between the left and the right arm per se. But in this MCQ, he was rather talking about BP, which is relatively increased in the patient in the upper limbs. If you look at option number C, aortic dissection, that will cause severe chest pain in the patient, hemodynamic instability, not present in this case. PAN mainly presents with the kidney involvement. There's a kidney involvement without a glomerulonephritis, so you have a hematuria with a hypertension, but you don't read about BP being increased only in the upper limbs. That's very characteristic of narrowing of the aorta for coarctation of aorta. So the correct answer for this question is option number Bombay. Another question on CKD, he mentioned ECG finding of tall T waves. We very well know in hyperkalemia, as potassium will go up, the magnitude of the height of the T waves will also increase. And he says what metabolic derangement is likely to be present in these patients. So anybody who's having tall T waves, we will think in terms of hyperkalemia, but hyperkalemia is not in the options. There is no hyperkalemia present in the options. At least this is what I found from my students. There was hypokalemia present, so ruled out because hypokalemia would be having rather a T wave inversion. Hypocalcemia, yes, when it comes to CKD, we very well know the fact that these patients would be having a deficient production of vitamin D3, and when vitamin D3 in the body will decrease, calcium values will definitely be lesser. So this looks like a plausible answer. Hypernatremia, most patients of CKD will be having a volume overload, and because of this volume overloading, these patients would be having a hyponatremia. In fact, patients of CKD have a hypervolemic hyponatremia, so I'm ruling out option number C as well. In all patients of CKD, there is impaired excretion of phosphate because ultimately if GFR is not there, phosphate will never reach the tubules. Therefore, phosphate will not be excreted. So we rather have is an elevated phosphate. All patients of CKD have an elevated phosphate. Every time you read hyperphosphatemia, CKD should always come in your mind. But in this MCQ, it is written hypophosphatemia. So I have ruled out option number D also. The correct answer for this question is Bombay, hypocalcemia. That's primarily because of the fact that in the patient there will be less synthesis of vitamin D3, and that will explain the secondary hyperparathyroidism in these patients as well. So he gave you a question of electrolyte imbalance from the perspective that it looked it's gonna be hyperkalemia, but that was anyway not present in the options, and these patients would be having metabolic acidosis also because the kidney will not be able to excrete hydrogen ions as well. Coming to the next question, he's talking about a 10-year-old girl who's having myoclonic jerks. Since last 1 month, the class teacher is also complaining to the parents about the poor scholastic performance of the child, lack of concentration. So when I read about myoclonic jerks and poor scholastic performance, child is not able to complete homework, classwork, though initially the child was maybe a brilliant child, we are talking about neurodegeneration. The past medical history is significant for viral exanthema at 2 years of age. So you can very well pick up the fact that this child might have had a viral infection at a young age, and now by 10 years of age, the slow virus disease. I think I've given a substantial hint to you guys. The slow virus disease has taken a toll and has caused a neurodegeneration. The EEG of the patient shows a burst suppression pattern. So whenever there's going to be a panencephalitis, whenever there's going to be a cortical injury to the patient, then burst suppression pattern can be present in the terminal stages of the disease. In fact, in patients who are suffering from subacute sclerosing panencephalitis, which is the diagnosis of this case, you can notice that I've described this in the epilepsy section, that if a child suffers from infection with the altered measles virus at 2 years of age, this virus can cross the blood-brain barrier and damage the neurons, and it can cause myoclonic epilepsy. In patients of subacute sclerosing panencephalitis, there would be neurodegeneration. So the child who was a brilliant child at school, good at mathematics, good at all subjects, would be lying in the house, staring at the walls. And this child who could earlier control his bladder is now urinating in the bed itself. The child cannot walk, he cannot talk. So that's the manifestations of neurodegeneration per se. The clinical diagnosis of this patient is SSPE, and as far as EEG of these patients is concerned, I want to highlight that initially these patients will be having slow waves in the EEG. If you remember my discussion of variant Creutzfeldt-Jakob disease, I used the term periodic sharp wave complexes. That is, in the background rhythm, there will be some sharp waves present that would be coming approximately every 1 second. So we call it periodic sharp wave complexes against a background rhythm. In subacute sclerosing panencephalitis, we again get these periodic, I would say, sharp complexes, but these complexes are occurring at a very irregular interval. You see, just like I was teaching you, irregular pulse is a feature of atrial fibrillation. I'm now teaching you that if you're getting these periodic spikes, I'm saying them periodic still at the moment because they're occurring at least regularly, they're marching regularly, but at the same time you will notice that the distance between them, you see, you have to understand this from the perspective that the timing between the two spikes is not constant. They are occurring on a regular basis there, that is fine, but they are having, rather the periodicity is not maintained, in a sense that the gap between these spikes is different, and this is what is technically called as Rademacher complex, and is a very characteristic EEG finding that you encounter in patients of subacute sclerosing panencephalitis. But in the same patients, as the disease progresses, there can be a burst suppression pattern as well, which means the fact that this would be much more smaller spikes present. So in contrast to the magnitude of the spikes, now the magnitude of spikes will decrease as the disease will progress. But I'm not basing my diagnosis only on the basis of EEG. I did not base diagnosis of this MCQ as SSPE on the basis of EEG. Rather, it was past medical history, viral exanthema, neurodegeneration, and myoclonic jerks. That's the standard presentation. In the exam, every time they're going to give you myoclonic jerks at 1 year of age, you always are going to think in terms of salam seizures. If it's going to be between something like 5 to 10 years, it is SSPE. If it's 10 to 19 years, it is juvenile myoclonic epilepsy. If it's 35 years of age, it is variant Creutzfeldt-Jakob disease. And for diagnosis of SSPE, I need to demonstrate presence of antibodies against the measles virus in the CSF. So therefore, if I look at option number 1 and 2, option number 1 is valid for Guillain-Barré syndrome. Option number 2 is mainly valid for Miller-Fisher syndrome. When it comes to anti-MOG, myelin oligodendrocyte globulin, this is the one that you get in some cases of neuromyelitis optica. I'm just writing plus minus in neuromyelitis optica because usually neuromyelitis optica, the antibody that is found is anti-aquaporin 4 antibody, but in some of the variants you might actually get anti-MOG antibody as well. When it comes to this MCQ, I can very safely say that the correct answer for this question is option number delta. Anti-measles antibody in the CSF is what is recommended, and there's a table also. If you go through the epilepsy discussion of mine, I've spoken about subacute sclerosing panencephalitis where EEG findings and the CSF findings of the patient have been described. Definitely the findings are initially periodic, but gradually the voltage gets suppressed as well, and when you evaluate the CSF of the patient, you will be able to notice antibody titers which are progressively rising. As the disease progresses, the antibody titer will rise. But obviously, in India, you are not going to do a lumbar puncture of the patient again and again. So, if you demonstrate increased proteins, if you demonstrate there are antibodies specifically with respect to the measles virus, the diagnosis of subacute sclerosing panencephalitis can be made per se. And anyway, as I highlighted, I mean, you can solve this question on clinical grounds on the age aspects that I said. Every time you read myoclonic jerks less than 1 year, that's gonna be presentation of Salam seizure, 5 to 10 years SSPE. I repeat that again, 10 to 19, juvenile myoclonic epilepsy, Jan's syndrome, and around 30, 35, 40, it's always gonna be variant Creutzfeldt-Jakob disease. I agree, age is never a criteria for diagnosis of a disease, but usually these are the four scenarios for myoclonic jerks that have come in the exam at different parts of time, highlighted in the epilepsy section. So I definitely would like you to listen to epilepsy and electrolytes component definitely very thoroughly at least twice so that you're able to handle all such questions. Coming to the next question, he asked you regarding a patient who's having ECG findings of MI and had undergone a PCI with stenting. He says, what drug will you add along with aspirin? The bottom line is, in all patients who have undergone a percutaneous coronary intervention with stenting, because you have put stent in the coronary artery, and stent is itself a foreign material, so it can trigger development of thrombosis. So to mitigate the chances or to reduce the chances of development of this stent thrombosis in future, it is recommended that these patients would be started on DAPT, that is dual antiplatelet therapy. This is the textbook reference from Harrison, which mentions the fact that in all patients who are having a drug-eluting stent, to prevent the development of latent stent thrombosis, dual antiplatelet therapy should be given for at least 1 year post a non-ST elevation MI or a ST elevation MI per se. So therefore, the correct answer for this would be option number C, that is P2Y12 inhibitor, that would be clopidogrel per se. From your pharmacological domain, you very well know the fact that PD5 inhibitors are the ones which would be like sildenafil, tadalafil, which are useful for management of high altitude pulmonary edema. Direct or oral anticoagulants like dabigatran or rivaroxaban, they would be useful in non-valvular atrial fibrillation. That would be secondary to, let me say, cardiomyopathy per se. So the bottom line is that DAPT, when it is used, dual antiplatelet therapy is nowadays recommended in patients who are admitted with a diagnosis of acute coronary syndrome. In fact, if you listen to my discussion of STEMI or non-ST elevation MI in acute coronary syndrome topic, I especially talked about role of dual antiplatelet therapy. Over and above this, I've also mentioned any patient with TIA, transient ischemic attack, we should be giving a dual antiplatelet therapy. But if we document somebody is having, let me say, rheumatic heart disease with mitral stenosis and he's having a atrial fibrillation, then I will give warfarin to prevent the development of stroke. So two separate aspects. One is a person had a TIA due to atherosclerosis. Second is a person who's having risk of embolic stroke secondary to mitral stenosis, secondary to atrial fibrillation that develops and the clots that develop in the left atrial appendage. Then dual antiplatelet therapy is also recommended for patients who are either undergone an intervention like coronary artery bypass grafting, or for that matter of fact percutaneous coronary intervention with stenting. If I shorten the third point, I can say any patient undergone a revascularization strategy for the heart would be a candidate for dual antiplatelet therapy per se. The subsequent question mentioned about a patient who's presenting with numbness and color changes in the fingertips. So he is pointing towards Raynaud's phenomenon. You very well know the color changes in Raynaud's phenomenon would be from white to blue and red. The patient is also having a shiny face with a face tightness. Now, the moment you read the word tightness of the skin, you are thinking in terms of possibility of scleroderma, because in scleroderma there's fibrosis below the skin. Anti-nuclear antibody is positive, but ANA is positive both in SLE as well as in patients with scleroderma. So the key in this MCQ is the immunofluorescence study that shows a nuclear pattern, because in SLE it will obviously be different to be diffuse pattern per se. The correct diagnosis of this question, even if you don't focus on the keyword of nuclear pattern, the answer would still be given as systemic fluorosis. If I just focus on the clinicals, that is combination of Raynaud's phenomenon, which is one of the earliest presentations of scleroderma, along with development of skin tightening. I mean, in earlier times, they were simply saying young female presents with skin tightening, or they used that classical term leather-like skin. But in this MCQ, that classical term leather-like skin was per se not used. which could have resulted in error of judgment secondary to anti-nuclear antibody positive. So lots of guys casually answered SLE, but I think that if you read the question and read it in between the lines carefully, the diagnosis in this question can definitely be picked up straight on. When it comes to the pattern, that's anyway discussed in pathology as well, so I'll let the pathologist handle that. The next question talks about features of cocaine toxicity are all except. Now, cocaine per se would be a rave party death per se. I mean, this guy, he's a teenager. He went to a rave party after paying hefty fees, and for the first time in his life, he's taking drugs, and that is, he's overdoing drugs. He's snorting cocaine. Cocaine is a very powerful vasoconstrictor, so this can constrict the coronary arteries, contributing to a high possibility of MI. So when you usually read regarding a young teenager going to a rave party and dying, that's because of the overdosage of cocaine, and MI would occur in the patient. When it comes to hyperthermia, again I can say sympathomimetic stimulation present here would explain the hyperthermia. So is the I would say the aggressive behavior. I mean, this guy might be thinking that he might dance the entire night away, but obviously, once a person is under the influence of drugs, it's not that physical activity will help him get over the influence of drugs. Ultimately, his heart will fail him and he can die because of MI. Because of sympathomimetic stimulation in these patients, you would be having a tachycardia and not having a bradycardia. So the correct answer to this question would be option number alpha. Coming to the next question, he talks about a 68-year-old patient who's presenting with cough and sputum. The patient is well oriented, the blood pressure is pretty stable, 110 by 70, but the respiratory rate of the patient is definitely increased, 20 per minute. So the bottom line is that he's talking about a lower respiratory tract infection because we're having a combination of fever with fast breathing. In fact, my diagnosis is clear further because he mentions the word bronchial breath sounds being heard in the patient. So I am thinking in terms of a lobar pneumonia developing in this patient. He mentions the fact that the lab report of the patient shows urea of about 44, normal is about in the range of 5 to 20. So definitely the urea values are about double of normal. And he says, what's the treatment protocol from the perspective of whether you would admit the patient, would you treat him on a home basis, or would you be admitting him to an intensive care unit? Well, all you need to do is curve or deploy the curve 65 score, and you would be definitely able to determine what is the best treatment protocol for this patient. Alphabet C would stand for confusion. Now I'm just putting a cross here to say person is well oriented, so therefore there's no confusion per se. When it comes to U, it is basically blood urea nitrogen, whereas in the MCQ it was given urea. So how do you convert urea into blood urea nitrogen? You just need to multiply whatever is the value of the urea that is given in the MCQ. You need to multiply that value by 0.35. Now obviously in the exam you will not have time to multiply 44 by 0.35. So I'll just use a single digit here, 44 multiplied by 0.3. Listen to my words very carefully. This would work out to something in the range of a blood urea nitrogen of 13.2 milligram percent per se. And in the classification, if you read curve 65 score, you will notice 1 values more than 7, because in the patient the values of 1 are almost reaching double of normal, because I multiplied only with 0.3. I could have multiplied it by 0.4 also. Even then, I mean, this value is definitely satisfied. So 1, this particular chap, this urea is of concern, and this blood urea nitrogen is definitely of concern. And over and above this, when I look at the third parameter, respiratory rate more than 30, I'm putting a cross because in the patient it is given to be 20. So it is still 1 mark at the moment. When it comes to the blood pressure of the patient, if BP is less than 90 by 60, it is 1 mark. I'm just giving a 0 even for that, primarily because the BP in this case is 110 by 70, but the age of the patient is definitely more than 65. Therefore, I can say two things which are the troublemaker for this particular patient is, one is the age more than 65, and second is the derangement of urea slash blood urea nitrogen. I've just interconverted the values also. Now let us look at how do we deploy this. There is absolutely no controversy, guys. He says whenever the patient score is about range of 0, that means definitely home treatment can be given, mortality rates are lesser. But when the score is between 1 or 2, now he highlights the fact that it should not only be the age of the patient that you are having a score of 1, I mean, it should be any parameter other than 1, but the bottom line is if the score of the patient is between 1 or either 2, irrespective of the 2. Like in this case, it is a score of 2 because age was also elevated, blood urine nitrogen was also elevated. So in this case, he says hospitalization will definitely be necessary. But suppose in this MCQ, there was a third parameter coming up, respiratory rate of the patient is more than 30. If the score was 3, then there would be definitely a ICU admission that would be required in this case. Considering the score of the patient is turning out to be at least 2, therefore in this patient, inpatient requirement is definitely on. I'm ruling out option number B because for this I need a score of at least 3. I'm ruling out option number C primarily because outpatient department that would be requiring a score of 0. And when it comes to option number D, indications for mechanical ventilation are primarily a comatose patient. Indications for mechanical ventilation would be a person who's not able to secure his airway primarily. So even this one goes off the radar in our patient. I mean, he's a well-preserved patient, at least from the perspective of his sensorium, because it is written he's well-oriented. So considering the fact that a well-oriented patient, there would be no reason why we would like to intubate the patient. The correct answer for this question would be an inpatient room-based treatment. The subsequent question is a big fight between forensic medicine and general medicine. There is a laborer who's working in extreme heat and he fainted. When you examined him, his skin turgor was reduced, definitely because he's going to sweat profusely, there's going to be water loss from the body, and there would be a development of hyperthermia because the thermoregulatory mechanisms will fail at one point of time. The question says which of the following is least likely to be seen in this patient, and the first obvious answer is sweating. I want to tell you the fact that in forensic books, it is always mentioned that when it comes to heat stroke per se, whenever there is going to be, a CNS manifestation occurring in a patient, then heat stroke is characterized by absence of sweating. But this is a very old concept. It is given in forensic medicine books. In actuality, think about it. If you are having a patient of heat stroke, there is also possibility that he might still be sweating, but he can still develop heat stroke even when he's sweating at the moment. Primarily because of the fact that sweating, it's not that sweating will stop completely and then heat stroke will occur. That's the usual impression we get. You see, it's an ongoing process. It's not that sweating will stop completely and then heat stroke will occur. Heat stroke can occur even earlier than that also. So when I give you the reference from Harrison, he mentions the fact that when it comes to exertional heat stroke in a person, which occurs in younger patients, most of them are doing physical activity, you definitely get sweating in these patients, you get diaphoresis in these patients. Please appreciate the fact that heat stroke means thermoregulatory mechanisms have failed. It does not mean that sweating has stopped. There's a cutaneous vasodilation. The body is trying to lose the heat, but the amount of heat being produced is so much because of physical activity that the heat loss and the heat production both are having a mismatch. If the heat production and the heat loss are equal, person would be fine. But when the thermoregulatory mechanisms, when the blood vessels are dilated to the hilt to the maximum and still the body is not able to lose heat, that is when CNS malfunction will occur. So it's an old concept which I used to study when I was at your age, that sweating will stop. That is when heat stroke will occur. The current concept is that sweating diaphoresis will definitely occur, fast breathing will occur. There would be a tachycardia present in the patient. So the question was very smartly disguised, guys. If you go through the Harrison discussion with respect to heat stroke, he mentions the fact that in heat stroke there has to be presence of three things. What are those three things? He said there should be presence of exposure to heat stress. So a laborer working in the extreme heat of Dubai is a heat stress. There should be a CNS malfunction. The core temperature should be more than 40.5 degrees. These three things should be present in the diagnosis of heat stroke per se. He has not mentioned anything like a diagnostic criteria of absence of sweating. And I've already explained to you that in the table with respect to exertional heat stroke, he has mentioned that the sweating would be present in a patient. If it is going to be a classical heat stroke, yes, he says possible. He says possible anhydrosis, absence of sweating. But that's a very, very late feature, guys. Initially, what you get in these patients would be a development of, as I said, tachycardia, very much given in Harrison, whereas in the MCQ, he mentioned which is least likely the answer for this would be bradycardia. I want to highlight this fact once again. When I was a student your age, I was taught this: when sweating stops, heat stroke. agree to that from forensic domain, but from the medical perspective, I want to say that sweating is an ongoing process. It is not that only when the sweating will stop after a few hours that you will say, okay, अब इसको heat stroke हो गया. There has to be, a ongoing heat loss occurring from the body, heat production also occurring, and when heat production is more than the heat loss and the critical threshold to which the brain can handle is lost, that's when the core temperature goes beyond 40.5 degrees, the person will lose consciousness per se, but there will definitely be a cutaneous vasodilation, there will be a sympathomimetic drive in the patient, causing a tachy and not a bradycardia. The subsequent question was relatively easier one. He said a patient with giant cell arteritis, that's a vasculitis, presents with headache, jaw claudication and polymyalgia rheumatica, pain in all the joints. Jaw claudication is one of the highlights of this condition because auriculotemporal artery is becoming narrow, so therefore the blood supply to the TM joint per se becomes lesser, and therefore the manifestations of pain on eating would develop, and similarly ophthalmic artery involvement can cause even blindness in these patients. So because it's a vasculitis, I shall be using steroids. Yes, we have used subsequent immunomodulators for these patients as well, but considering that these strong immunomodulators mentioned subsequently, tocilizumab, tofacitinib, etanercept, can be having side effects also, reactivation of latent tuberculosis, steroids would be the first line management for this patient in fact. The answer to this question is option number alpha, as described in the routine discussion as well. And I've highlighted even the Harrison reference that whenever a person is having cranial or large vessel disease, right? When I say cranial, it would be primarily indicating auriculotemporal artery, branches of external carotid, branches of internal carotid artery. He says the first line treatment for this would be glucocorticoid therapy primarily for the person. The subsequent question was regarding a 35-year-old man with low backache and morning stiffness. Now there were two questions I think on ankylosing spondylitis this time, because both mentioned a male with a backache with a stiffness. The only thing was in one case it was a patient relatively younger, 10 to 15 years of age, and then he mentions in this question that the chest expansion of the patient is also reduced. That's because of the costochondritis component in ankylosing spondylitis. Osteoporosis will obviously occur in a female postmenopausally. Disc prolapse, well, when it comes to I would say the X-ray image of this patient, the classical bamboo spine, the osteophytes that can be seen. So everything about the question is just crying out loud that, answer me at an ankylosing spondylitis. No tricks in this question. I mean, no per se a presence of any neurogenic claudication, because prolonged standing causes pain in especially patients with disc prolapse, and there's no deformity of the spine, no gibbous present, no focal erosions present to think in terms of port spine as a possibility for this case. The answer to this question is option number C. The next question talks about a 10-year-old child who's having features of rickets which are not improving with vitamin D3 supplementation. So what I'm thinking in terms of is an end organ resistance or a problem with the receptors of vitamin D3, that is vitamin D dependent rickets, where there's a problem with either the conversion of active forms of vitamin D or production of active forms, or there could be a problem with the receptors of vitamin D, or it could be a case of a phosphate wasting per se, where there would be hypophosphatemic rickets secondary to the FEX gene defect. Now let's select from the options which are present based on the biochemical values, because calcium values are strikingly normal. Whenever it is a vitamin D dependent rickets, we always find that because vitamin D is not able to act on the bones, or active form of vitamin D is not being produced, calcium values are always less in a person who's having vitamin D dependent rickets. But in hypophosphatemic rickets, the values of calcium will be normal. It is mainly a significant depletion of the value of phosphate. I'm very sure in this MCQ, everybody could rule out distal renal tubular acidosis. There is no metabolic acidosis that is developed in this case. And especially when it comes to distal renal tubular acidosis, most of the time we could also be having concomitant problems of nephrocalcinosis. There would be electrolyte imbalances in the form of hypokalemia. And because in this particular question, none of that information was present, so I am keeping this lower in the order. When it comes to hypoparathyroidism, then you can easily rule out option number D, because in hypoparathyroidism, PTH values will be lesser. So you're stuck between A and B, and I'll just show you a table which will make it easier for you to comprehend this. You see, when it comes to hypophosphatemic rickets, the problem is not of calcium. It is Phosphate forms an important component of calcium hydroxyapatite, which makes the bone strong. If you lose phosphate, the calcium hydroxyapatite component is also affected. So the bone is defective and therefore manifestations like rickets can develop. So one of the highlights of hypophosphatemic rickets is that there is a normal serum calcium and a normal PTH. In contrast, when it comes to a person who's having a problem with respect to the receptors, or let me say dependent rickets per se, you will always notice that calcium values will be lesser, simply because if vitamin D is not able to act on the tissues, calcium has to be lesser. So one of the key words in this MCQ was normal serum calcium with a low phosphate. In fact, this is the statement I want you to remember, that if you get a question in which calcium is also less, phosphate is also less, SAP is elevated, nutritional rickets. But if you get a question in which calcium is normal, still you are having rickets manifestation with a very low values of phosphate, that's 2 milligram. I mean, normally it would be much higher than that, something in the range of about 3.5. So since the phosphate values in this case are dramatically reduced, we have to think in terms of a hypophosphatemic rickets. The answer to this question will work out to be option number beta. The next question talks about a 52-year-old postmenopausal lady with severe backache and a history of Colles fractures thanks to the osteoporosis component, and her bone density is also very low because DEXA is showing a score of minus 2.5 standard deviation below normal. Question says which of the following is wrong about her management. Now I know the fact that you would definitely like to debate it out with me, so I have taken references here for each of the four options. A says teriparatide can be given before bisphosphonates. Agreed that bisphosphonates are the first line treatment for any patient who's suffering from osteoporosis. But let's look at what's current medical diagnosis and treatment. This is a snapshot from CMDT 2021. It mentions the fact that the preferred sequence, if you want to give a combination of, you see, bisphosphonates are definitely going to be the anti-resorptive agents, but when it comes to teriparatide can be given before starting the patient on bisphosphonates. So let's look at the statement. He says when given in sequence with the anti-resorptive agent, the preferred sequence is to first give PTH or PTH-RP related peptide followed by bisphosphonate or denosumab primarily. So let's look at option number A again. Teriparatide can be given before bisphosphonates. Definitely yes. It's not that only bisphosphonates are used. If you want to use a combination, especially in patients who had a fracture per se, you can definitely use teriparatide for their bone strengthening effects. And therefore, this statement is a direct lift up from current medical diagnosis and treatment, that if you're using a PTH analog in a patient, I'll just zoom it in for your convenience. I mean, though the PDF would also be available in my Telegram group. Do notice this fact that he mentions the fact that you can give teriparatide, then follow it up with bisphosphonate. So this definitely is a correct statement, and there's a reference for it. Option number B is bisphosphonates can be used for about 1 year. You very well know that if bisphosphonates are used for long duration, that is beyond 3 to 5 years, in fact most books say 3 years, then there can be a development of fracture of the shaft of the femur. It would be atypical fracture. Most of these patients will be having continuous thigh pain, and then one day they will simply not be able to walk, and when you do an x-ray, obviously you will find a fracture of the femur, which is really unfortunate. So when you read about bisphosphonates, one, you can read about osteonecrosis of the jaw, and apart from osteonecrosis of the jaw, atypical fracture of the femur can be present. So this is the wrong statement, and this is the answer to this question. Why? Because bisphosphonates are usually used for not beyond 3 years. Let me show you the reference for the same as well. He says the half-life of bisphosphonate in bone can be up to 10 years. So the optimal duration for which they can be used depending on the subtype is 3 to 5 years. And if you use it beyond this, the risk of atypical femoral fractures will increase. And this statement of mine proves the fact that why B is a wrong statement, because I showed to you it should be 3 to 5 years. Let's look at C and D as well, though they are very obvious. Still, I mean, I am very being cautious with this question because they can just play around with words. This is the requirement of calcium meant for age above 50 years. In our question, the age of the patient was more than 50. He mentions men and women and older, 1200 milligrams on a regular basis. Younger than that, it's 1000 milligrams. So do remember age group. The calcium supplementation is mentioned, and he mentions this fact that along with this, these patients should also be taking vitamin D. And they also recommend that this vitamin D should not be taken in a bolus shot. I mean, you don't need a stoss therapies for these patients, rather it should be a daily vitamin D therapy. And the dosage of vitamin D in these patients can definitely be higher. I mean, in patients who have had a fracture or a documented osteoporosis, the dose of vitamin D can go up to 1000 international units as well. So I've given you Harrison reference for option number C and D, and between A and B, as I've shown to you, current medical diagnosis CMDT 2021 clearly highlights this statement that teriparatide can be used first, then can be bisphosphonates. Absolutely no problems with that. But bisphosphonate prolonged usage will definitely cause problems. So the answer to this question would be option number Bombay. So these are the important aspects, guys, that I would like you to remember with respect to the medicine discussion with the NEET PG 2021 paper. I have not incorporated some questions which are covered in pathology, like, but I'm just making a passing reference to those. That's gonna be like multiple myeloma, poor prognosis is gonna be urinary beta 2 microglobulin. Then they asked a question with CML and they said, what is the most sensitive test for diagnosis? So it will obviously be PCR/FISH. They anyway gave a scenario of a person having a basophilia with immature cells in the circulation which shift to the left, and they mentioned about a patient who's having a high LDL and tendon xanthomas, which is a feature that you see with the commonest lipid profile defect in the world, that is familial hypercholesterolemia. I mean, this is the commonest lipid profile defect per se that we see in clinical practice. So these are the details that I would like you to remember and practice with respect to this NEET PG entrance exam. And I do agree that this was a balanced paper. Some of the options were tricky. I mean, in every paper, some options will obviously be the tricky ones and going to be controversial ones. But I've tried to give references to each of the statements that I have mentioned here. And in case you have appeared this time and you're listening to this discussion, and if you find that any of my options are different from what actually came in the exam, do let me know in the comment box, so that, or in direct interaction in the app, you can post in the premium group, or you can mail me. In fact, I'll be more comfortable with the email, that's marwahmedicine@gmail.com, so that I would be able to improvise on this or improve on this document. And that way I think everybody would be benefited. So thank you so much for hearing me out, guys, and having the patience for sitting and hearing me that long. Bye bye, take care.